So last time I was live, we kind of ended right here. I have not streamed in like the last, I think, 4 or 5 days now, because I left Thursday night to Colorado. That was really fun. I was there for the Tough Mudder, which if you haven't heard of it, you should probably Google it. But the Tough Mudder is like a athletic event, I guess. It was a 10-mile run, not exactly a race. You're all in it together. So it was a 10-mile run where you go through various obstacles and stuff, and you're in the sun and it's pretty hot and all that. It was really intense, but at the same time it wasn't too hard either. A lot of people were doing it. Not everybody was fit and all that, so it's definitely something anyone can generally do. Very fun, very fun. And then if you're in Colorado, the main things you can do are like hiking, walking really long trails. I also went kayaking. It was nice. I enjoyed it. It was a very nature-based time, so good stuff. And then here I am now, back at it. So this is where we stopped last time. Um, we're now at hypothyroidism versus hyperthyroidism, right? So endocrine pathology, almost halfway through. We looked at the easier pathology so far. The rest of this is the slightly harder stuff, right? Even this is actually pretty easy. Hypo versus hyperthyroidism, not the most difficult thing on earth. I'm going to point out a couple things that a lot of people tend to forget. There's a lot of stuff about hypo and hyperthyroidism that people do always remember and understand, and everyone has a pretty good clinical picture when you close your eyes of how a patient should look if they have hypo or hyperthyroidism. Keep in mind, though, that these clinical pictures are based off of patients who are not treating their thyroidism, right? A patient with hypothyroidism that is treating it with levothyroxine will not have cold intolerance, weight gain, dry, cool skin and stuff like that, because they have the thyroid that they need, right? The hormone that they need. And similarly, a patient with hyperthyroidism that is treating it will not really, have onycholysis or very, very anorexic body type. They're not going to have intense weight loss and stuff. So we're going to get into that. Where this gets harder, endocrine path gets harder, is when you start thinking about the histology of the various thyroid cancers and all that, as well as when we finally get to SIADH and diseases of that similar function. And then later on, we're going to see the chart with the calcium and PTH and how that's supposed to mean stuff. So it's once again, it's not, none of this is memorization. You really have to understand what's happening. You really need to have a good clinical picture of it all. So let's dive into it, right? So hypo versus hyperthyroidism. Hypothyroidism basically is a patient who does not make enough thyroxine, right? They're not making enough T4, so they don't have enough T3 either, and their pituitary is going to start making a lot of TSH to really try to make more thyroxine, but it's not going to work because the problem is usually at the level of the thyroid where you're unable to make the hormone, right? So primary hypothyroidism. So without the thyroid hormone, way in the beginning of endocrine pathology, I said that almost any patient that comes in with any kind of issue, you need to check their TSH, because the thyroid hormone affects pretty much everything, right? I mean, metabolism in itself is a whole array of things that's being affected, but brain development, it can even affect mood. So hypothyroid patients can be depressed, right? There's that there's that aspect of decreased libido, right? There's a lot of stuff. It's related to everything. A patient can present to you with infertility, right? A question can literally start off looking like a reproductive question where they present with infertility. Well, if you've never checked this patient's TSH, you need to do that, right? A patient might be presenting with bradycardia, right? So you need to check their TSH. Like the thyroid hormone affects so many things that anyone that comes in, you definitely need to rule out hypo or hyperthyroidism before you can even go on to try making a diagnosis of any kind. So metabolic, and this is a nice way to divide it up, like all the different systems that are being affected. So metabolic, you're going to have cold intolerance, decreased sweating, you're going to have weight gain, which is definitely something people who have hypothyroidism will eventually notice before they start treating it, because there's a decreased metabolic rate, so decreased calorigenesis. There's also hyponatremia, so you have decreased free water clearance, all right? So they don't really pee too much either. And that's something you definitely want to see, as opposed to hyperthyroidism, where you have the exact opposite of that. So you have heat intolerance. You're always going to be too hot, right? There's going to be increased sweating, a lot of weight loss. The hyperthyroid patients are almost always going to be very skinny, because there's an increase in the sodium potassium ATPase, which then leads to more calorie genesis, right? So you want to watch out for that. This little answer choice of increased sodium potassium ATPase is something they can put instead of putting increased basal metabolic rate. And yeah, the thyroid hormone can be abused for weight loss, but it's not something that you should really do, and it's never something that's recommended either, because if you have excess exogenous thyroid hormone intake, if you're taking too much levothyroxine, it will mess up the TSH axis, right? Your HPA axis of hypothalamic pituitary, not HPA, well, HPT axis, I guess, right? Hypothalamic pituitary thyroid axis, because you're going to stop making more TRH, you're not going to make more TSH, and you're going to be eating a lot of thyroid hormone. When you stop eating it because you feel like you've lost enough weight or something, you're still not going to make much TSH, and your body's just going to get all messed up. So you definitely don't want to do that. Skin and hair, so you see similar things again, right? So if you have cold intolerance, you're always freezing. If you're freezing, you're going to have dry, cool skin, right? Decreased blood flow, so you have cool skin. Coarse, brittle hair, diffuse alopecia, brittle nails, puffy faces, and generalized non-pitting edema, which is known as mixed edema, due to increased glycosaminoglycans in the interstitial spaces. So if you have a lot of gags in the interstitial spaces, that increases your osmotic pressure, which again is something that can be an answer choice, right? Increased osmotic pressure, and that's going to lead to more water retention. So you have decreased free water clearance and water retention, which obviously will very much look like you have edema or something. In hyperthyroidism, where you were always hot, you're going to have warm, moist skin due to vasodilation. Right? And remember, from your receptors, vasodilation is related to your beta-2 receptor. And related to alpha-1. Alpha-1 causes vasoconstriction. You're going to have fine, thin hair, onycholysis, right? Which onycholysis is kind of like cutting up of your nails. There's going to be a lot of lysis in the nails. And pretibial myxedema in Graves' disease. So keep in mind that you do see myxedema in both diseases, but in Graves' disease, which we're going to get to soon enough, Graves is very specific to a certain category of hyperthyroidism, where you're going to see myxedema, pretibial myxedema, and that's really all you're going to have. Right? And the other thing you're going to see is the ophthalmopathy, where you have periorbital edema, and the eyes are kind of pushing out in Graves' disease. Those are your hyperthyroidism things, right? As far as ocular stuff, you only have periorbital edema in hypothyroidism, but in hyper, you have periorbital edema with the exophthalmos. You're going to have lid lag, retraction because of more sympathetic stimulation of the levator palpebrae superioris. And this, again, is another fact that you can have as an answer choice, right? You're not going to have exophthalmos as an answer choice, but you could have this one, the levator palpebrae superioris, having more sympathetic stimulation. Right? That's the muscle that's innervated by the ipsilateral superior oculomotor nerve. Right? So very important to remember that one as well. As far as gastrointestinal, there are exact opposites there too. So hypothyroidism patients are going to have constipation and decreased appetite, but they're gaining weight, right? And this is all related to a slower metabolic rate. Whereas in hyperthyroidism, they're going to have increased GI motility, so it's going to look like diarrhea. It's not really diarrhea. I think hyperdefecation is definitely a better word to go with for that. And they have an increased appetite because they have such a high metabolic rate, right? They're metabolizing everything really, really quickly. Musculoskeletal is very interesting. This is usually something that comes up in questions as part of the physical exam, right? So in hypothyroidism, you're going to have proximal muscle weakness, increased creatine kinase, right? You can have carpal tunnel syndrome, myoedema, and myoedema is something that UWorld even puts into question. This is when you have a small lump rising on the surface of a muscle when struck with a hammer. That doesn't happen in hyperthyroidism. In hyperthyroidism, you're also going to have proximal muscle weakness and normal CK. Right? So the proximal weakness is there, but there's no creatine kinase in hyperthyroidism. But in hypo, you have elevated CK. There's also osteoporosis and increased fracture rate because T3 directly stimulates bone resorption, which again is a fact that a lot of your medical student buddies probably don't even remember, and you might not know either. So definitely something worth talking about more, because we always remember things we talk about all the time, But no one really, this isn't the first thing you describe when someone tells you to describe something about hyperthyroidism. You're going to be like, oh yeah, osteoporosis and fracture rate. No, everyone talks about Graves and stuff like that. So keep this in mind, right? Hyperthyroidism can lead to increased fracture rate because T3 directly stimulates bone resorption. No one really thinks of bone resorption when they think of T3. When you go down to reproductive, this is another really specific section that can really get tested because of the libido aspect, right? So a patient can come in with decreased libido, complaining about it. The question can get very confusing if they have other medications that the patient might be on, and you might not remember if those medications also decrease libido. Some of them might even be psychiatric medications, and they have nothing to do with libido, but you might not remember, right? So definitely something worth considering when it comes to thyroid. And infertility. A female patient who is not menstruating regularly, you need to check their TSH. Definitely something you want to do immediately if it hasn't been done, right? Abnormal uterine bleeding, AUB, is a relatively newer thing. AUB, abnormal uterine bleeding, which when we get to reproductive, we're going to see that this is the more preferred phrase now, as opposed to many of the previous phrases people used to use to describe different types of abnormal uterine bleeding. In hyperthyroidism, you can actually get abnormal uterine bleeding, gynecomastia, libido decreasing, and infertility. Now this is cool because you can see in both sides the libido decreased and infertility occurred. Right? So it's the same thing in both hypo and hyper, which is rare. Right? Usually everything was opposites. Here it's the same on both ends. You need your thyroid hormone to be at just the right level for it to not negatively impact your fertility and negatively impact your libido. Right? So in both hypo and hyper, libido decreases and you have infertility in both of them. The gynecomastia thing is also pretty interesting because you can have gynecomastia in both cases as well. All right. One thing we saw earlier in endocrine was that TRH actually also upregulated prolactin release. Right, so you can have gynecomastia in reproductive as well. I think this image here is talking about the menstrual irregularity study. Let me just go back to something real quick. Let's see. Yeah, right here we have our thyroid stuff, thyroid hormone. Yeah, see, remember that TRH also upregulates prolactin. So a patient who is hypothyroid, right, their hypothalamus will make more TRH to tell the anterior pituitary to make more TSH. This same TRH also goes and upregulates prolactin. Right, so if you don't start treating the hypothyroidism and bring your TSH levels back to normal again, you're going to have hyperprolactinemia, which also decreases libido and can cause infertility and can cause gynecomastia. So you can have gynecomastia in both cases. Neuropsychiatric, see, now another system that's affected. So you can see, right, each one of these is basically another system that's being affected. So if a patient comes in with any issue regarding any one of these systems, you need to check their TSH. Neuropsychiatric, hypoactivity, lethargy, fatigue, weakness, depressed mood, right, delayed slow relaxing because they have decreased reflexes. Very bad. All of this is something that a patient can present with, mainly the depression aspect, and you need to check their TSH. When you go over to the other side of the spectrum, you have hyperactivity, anxiety, insomnia, fine tremors because of the increased beta-adrenergic activity. Remember from the thyroid page that you upregulate beta receptors, mainly beta-1 receptors, so you're going to have increased activity from that leading to fine tremors, and you have increased reflexes, right? Which isn't exactly the best thing either because these patients are not really doing well. Finally, you come down to cardiovascular, so you have bradycardia and dyspnea on exertion, decreased cardiac output, right, from cardiovascular. But in hyperthyroidism, you have tachycardia, palpitations, you can get atrial fibrillation in these patients, if you don't treat it, chest pain, systolic hypertension due to more beta receptors, and they're more sensitive now, increased expression of cardiac sarcolemmal ATPase, and decreased expression of phospholamban, which are important things that we've already discussed when we were doing the cardiovascular chapter. Right, remember that the sarcolemmal ATPase uses ATP to bring in calcium into the sarcolemma so you can have stronger contractions next time. Phospholamban is the guy that inhibits your sarcolemmal ATPase from actually working. If you're upregulating all the beta receptors, you're going to be phosphorylating the phospholamban and stopping it. So now phospholamban can no longer stop sarcolemmal ATPase, and you're going to have more contraction, right? And that's kind of what's happening in these patients, and that's kind of what I'm reiterating right here as well, with the epinephrine and norepinephrine binding beta-1 receptors, GS, PKA, cyclic AMP, all of that. Right? Very important details to keep in mind. And then finally we have our labs, right? So what do we see in labs? So the most sensitive indicator of thyroid function when it comes to lab work is your TSH. It's going to be up or down almost immediately based off of how much free T3 and T4 you have. And one cool thing, one specific thing you want to watch out for in both hypo and hyper, I mean, obviously, you know, if you're hypothyroid, especially if it's primary hypothyroidism, you're going to have elevated TSH and low free T3 and T4, right? It's secondary hypothyroidism if you're not even making TSH. And then in hyper, you know, if your thyroid hormone is not, if your thyroid gland is not making any thyroid hormone, your TSH is making too much thyroid hormone, your TSH is going to be low, right? So that's the most predictable stuff. That's pretty easy stuff. But in hypothyroidism, you have hypercholesterolemia. And this is something that can pop up in a question because it's, once again, something that people might not really think of. So you have decreased LDL receptor expression, which means you can't really pick up your LDL and bring it back to the liver again. So you end up having too much LDL in your blood vessels, and that's the hypercholesterolemia. You can get atherosclerosis, etc., over time. Now remember though, atherosclerosis, when we talked about it, was something that took years to really become problematic. So a patient who is hypothyroid usually won't stay hypothyroid for years, right? Because eventually they're going to come into a doctor and get checked and then treated, right? And they're going to start taking their thyroid hormone, their thyroxine, and they'll be okay. So atherosclerosis isn't exactly something we mention when we get to hypothyroidism, but if you have a patient who hasn't seen a doctor in over 10 to 15 years and they've been hypothyroid for that long, on top of the other things that might be wrong with them, and based off of their diet and etc., they can have atherosclerosis because of the hypothyroidism, right? And it's the other way around for hyper, where people are very skinny and they have increased metabolic rate, so they have low cholesterol, right? Low total cholesterol, which also isn't good either. You don't want to have it too low either, right? Because they're also having very low HDL. So that's that. There's one question right here. This one's pretty cool. So you can see a couple things that were mentioned on this page that we talked about, and we pointed out more specifically, that gets brought up in this question. 45-year-old man comes to a physician with chronic fatigue and mild weight gain. When you see weight gain, you want to think of hypothyroidism. He has no chest pain, dyspnea, palpitations, or lower extremity edema. Patient has no other medical problems and takes no medications. On physical exam, a localized lump rises from the surface of the skeletal muscle following percussion of the muscle with a reflex hammer. His lab values are significant for elevated CK. Which test would be most useful to find out why CK is high? And you want to check for TSH. Just check the person's TSH. That's it. It's really easy. All the other answer choices made no sense. Common causes of myopathy with high CK are hypothyroidism, muscular dystrophies, and medications like statins and even fibrates, right? CK isn't always going to be high. It's not something that can be easily high. CK is high when you have MIs and stuff, but that's different, right? Remember that creatine kinase isn't exactly specific to the heart, so it can be high in any kind of muscular damage. In hypothyroidism, we have elevated CK with the hypothyroid myopathy, and we don't have elevated CK in hyperthyroidism, right? Normal CK in hyper. And on top of that, the other thing they're talking about here with the localized lump after percussion, that's your myoedema, right? Small lump rising on the surface. So physical exam, right? This question was a hypothyroidism question based off of the musculoskeletal system, right? But it's almost always extremely easy to pick between hypo and hyperthyroidism, and then finally getting to an answer choice. Now this answer choice was an easy one. They could have had something else that's more confusing from this page, so you definitely want to make sure you grab all the more less often spoken of topics from this page, because those are the things that you're going to get as your questions. In the last video, we actually stopped at VIPoma, right? We talked about it. We discussed a patient who has excess VIP, so you get WDHA, which is watery diarrhea, hypokalemia, and achlorhydria, and this was also associated with MEN1. Right, as were some of these other guys, right? From here we had insulinoma that was associated with MEN1, and not glucagonoma, but you did have this one, Zollinger-Ellison syndrome, also associated with MEN syndrome, MEN1. So down here is a question regarding the VIPoma. Let's take a look at that. So 32-year-old woman comes to the office due to persistent diarrhea. She has had 8 to 10 episodes a day of tea-colored, odorless, watery stools. The symptoms have persisted despite a lactose-free diet and a fasting trial, so it's not related to food intake. The patient has no abdominal pain, fever, or vomiting. Temperature is fine. Abdominal exam is unremarkable. Sampling of her gastric contents shows a total lack of gastric acid. Somatostatin treatment promptly relieves her symptoms, an excess of which hormone is causing her symptoms. So giving somatostatin fixed it, which means it was related to a hormone, right? That's something you always want to remember, because somatostatin makes things very static as opposed to dynamic. It makes things very neutral. Everything stops in a sense. So her symptoms are due to VIP. This patient has a VIPoma, which causes a secretory diarrhea, so there is no blood or pus. It's all watery. VIP stimulates bicarbonate and chloride secretion, and its binding to the intestinal epithelial cells leads to adenylate cyclase activation and increased cyclic AMP production, causing sodium, chloride, and water secretion into the bowel. And all of that pulls, a lot of things with it. It's a very osmotic gradient right there, and you get very heavily watery diarrhea. Right? Somatostatin analogs like octreotide decrease many GI hormones and are used as treatment for VIPoma. The other thing, menstruation, right? And I already stopped and talked about it. Pretty much the same in both hypo and hyper, and that's something that was unique. Whereas every other system, opposites were happening. Reproductive is going to have the same pathology in both hypo and hyperthyroidism. So you can't really diagnose someone for hypo or hyperthyroidism just based off of reproductive things. And that's a pretty important lesson to keep in mind. Because earlier we saw elevated CK, okay, it must be hypothyroid, right? We can do that because we know we have normal CK in hyper. If you see myoedema, again, it must be hypothyroid because we don't have that in hyper. If you have decreased appetite and weight gain, that's hypothyroid. But when you get to reproductive, if you have a patient that came in with decreased libido and infertility, plus some moments of abnormal uterine bleeding, you can't instantly label that as hypo or hyper. You don't know, because you get the same things in both. Right? So that's definitely something you want to watch out for. And then we started looking at all the different things that can cause hypo and hyperthyroidism. Now this here is actually pretty nice. This link that I put right here, you can, let me open it up so I can show it to you guys real quick. Okay. So you can Google to find this link, but basically here they have, you see, Endocrine Pathology Index. It's WebPath from the utah.edu website. Basically on this page they have non-stop images for you. You can see all the pictures of all kinds of things. You just keep going. If you press index, it brings you back to this list again, which is very nice. I find this such a easy web page to get around. And you can just do this at any time to really get a good understanding. It's not going to be the best understanding, but it's a lot better than anything else. You get to look at a bunch of pictures of stuff and really have an understanding of what it's going to look like, right? So you get gross pathology images, which are also great because you get images like this on the NBME and Step 1. Literally just like this, actually. So it's a good little practice thing. You can just keep going, look at different images. They describe it all to you. So I found this to be an excellent source to utilize. So now you have that. So the link, you can just Google it, or you can literally just type it in from here. But just search for WebPath Med Utah, and you're gonna get all these histo images. And it's for multiple glands. It's not just the thyroid either. So you got your pituitary, parathyroid, adrenal stuff, and your pancreas. So very nice resource. I would definitely recommend checking that out for more practice regarding histology and gross pathology. And that's here because we do have to know the histology of all the hypo and hyperthyroid situations we're about to look at right now. So the most common guy, Hashimoto thyroiditis, right? Most common cause of hypothyroidism in iodine sufficient regions like America, Canada, stuff like that. An autoimmune disorder with antithyroid peroxidase and anti-thyroglobulin antibodies. So you're making antibodies that kill your thyroid peroxidase and kill your thyroglobulin, associated with HLA-DR3, DR5, and with more risk of non-Hodgkin lymphoma, typically of B-cell origin. Never really seen a question where any of that gets tested. Maybe keep in mind the non-Hodgkin lymphoma stuff, right, which is non-contiguous. Keep in mind, if you don't know the difference between Hodgkin and non-Hodgkin lymphoma, every time it ever gets mentioned, you should Google it or go find it in, I think it's in HEMONC, and really make sure you remember the general basic that Hodgkin lymphoma is contiguous. So it's like in one, set of continuous stuff, whereas non-Hodgkin can be all over your body in different places. It's not very continuous. Of B-cell origin, though, here, right? So you want to make sure you know what the B-cell origin non-Hodgkin lymphomas are. Maybe hyperthyroid early in course due to thyrotoxicosis during the follicular rupture. And in histology, you're going to see something called Hürthle cells, which really aren't easy to see, so you're not going to be depending on that. What you will be depending on are the lymphoid aggregates with germinal centers, right? Germinal centers, and we see germinal centers in other places also, but the question stem is going to be so different that it won't really matter. So you can always associate germinal centers with lymphoid aggregates, generally speaking, with Hashimoto, since it's the most common cause. And here in this image, they really, zoomed in and have a very high magnification to show you a Hürthle cell, but it's not that high yield. You're not going to be using a Hürthle cell to actually figure out if an image is actually for Hashimoto. Okay. But you definitely need to be able to see the germinal center and stuff. Because that's where you're gonna know, and you're not gonna pick Hashimoto just because the question talks about a germinal center. You're gonna pick Hashimoto because you're gonna know more about the patient. And when we finish the rest, you'll know what I'm talking about. Because in postpartum thyroiditis, you also have germinal center formation, right? Lymphocytic infiltrate with occasional germinal center formation. But if the question doesn't have a pregnant woman in it, or a woman that just delivered under a year ago, then it can't be postpartum thyroiditis, right? So that's why you can go ahead and pick germinal centers to be Hashimoto only. You're going to have a non-tender thyroid, which is very important to remember. There's no pain in the thyroid gland. It's just being attacked by your own immune system, so it's not making any thyroid hormone anymore. And that's really all there is for it. HLA-DR3 is shared with Hashimoto and DM1, SLE, Graves, and Addison. And we saw that when we were in immunology. HLA-DR5 is something new. It's more recently been added into first aid, and it's for Hashimoto. Right. So when we were in immunology, I tried to show ways of memorizing which one is for what. DR3 is actually shared with DR3 has things that are in many others. So everything in DR3 is somewhere else as well, and you need to remember what their DRs are, because oftentimes that can help figure out the answer, but it's not something I feel like we use in tests to figure out an answer, so you don't really have to worry too much about it. Postpartum thyroiditis is self-limited thyroiditis arising up to 1 year after delivery, presents as transient hyperthyroidism, hypothyroidism, or hyper followed by hypo. Majority of women are euthyroid following resolution, and it does self-resolve, so it's okay. Right? Usually painless and normal in size. Next one is cretinism, congenital hypothyroidism. Severe fetal hypothyroidism due to antibody-mediated maternal hypothyroidism. And you're going to have thyroid dysgenesis, which is the most common cause of thyroid dysgenesis in the U.S. Iodine deficiency, dyshormonogenetic goiter. All right. Findings are your 6 Ps. So they have a picture here to show you that, right? So in B, as well as C. So you can see that there is some kind of developmental, not just developmental, physical visualization of what can happen because of cretinism. So you have the pot-bellied, pale, puffy-faced child, and you can see the puffy face aspect, right? With the protruding umbilicus, protuberant tongue, which is especially visible here, like it's just not normal, and poor brain development, because obviously your thyroid hormone is necessary for brain development, all right? Subacute granulomatous thyroiditis, also known as de Crevaine's thyroiditis. This one is also very easy to remember. So far, you really just need to know Hashimoto and subacute, because the others are going to fall into very specific patient types, right? This one is a baby, this one is a woman who recently delivered. Hashimoto can be anyone, so can this, subacute granulomatous. So there's going to be granulomas, right? And you're going to see that the histology has granulomatous inflammation. Without the granuloma, you can't ever call it a Corvain. The other thing about Corvain is the pain, right? So elevated ESR because of inflammation, they're going to have jaw pain and thyroid pain, very tender thyroid gland. So going like this is actually going to hurt, right? And we do this and you tell your patient to swallow so you can feel the thyroid gland move. You won't really feel the thyroid gland too much because it's not going to be big. It's not overproducing, it's underproducing. But it's gonna hurt them when they swallow and the thyroid gland actually passes your fingers. Self-limited disease, often following a flu-like illness, usually a viral infection, may be hyper early in the course, followed by hypo, which becomes permanent in 15% of cases. All right, so all of these keep saying early hyper, later hypo, and that's because in the beginning, you know, when the gland itself is about to quote unquote die, just imagine that the gland kind of exploded and all the thyroid hormone came out. So it's hyper early, but then now you're not making any more thyroid hormones, so it becomes hypo, and it's going to stay hypo later on. The next unique one is renal thyroiditis. Renal thyroiditis is basically fibrous replacement, right? So you have thyroid replaced by fibrous tissue with inflammatory infiltrate. So you're going to see that on histology as well. Fibrosis may extend to local structures like the trachea and esophagus, which will then mimic anaplastic carcinoma. We haven't seen anaplastic carcinoma, but we will. Anaplastic carcinoma has a very poor prognosis. And so if you get a patient who's presenting with something that looks like anaplastic carcinoma, you really want to figure out, is it that or is it renal thyroiditis? Because you don't want to tell your patient they have anaplastic thyroid carcinoma. They're going to be pretty sad about that. 1/3 are hypothyroid, considered a manifestation of IgG4 related systemic disease like pancreatitis, retroperitoneal fibrosis, or non-infectious aortitis. So any of these three guys and possibly any other IgG4 related systemic disease can be in your question stem. So if you have a question where a patient is presenting with symptoms of some kind of IgG4 related systemic disease, and then the question seems to be talking about thyroid stuff, or maybe your answer choices are about thyroid stuff, go with hypothyroidism, and remember renal thyroiditis with fibrosis. So what do you find here? You're going to have a hard, rock-like painless goiter. There's just a lot of fibrosis right here. And if their trachea or esophagus are involved, the question might actually start with patient having a change in their voice, difficulty breathing, difficulty swallowing. It could be any of that. All right. The retroperitoneal fibrosis can decrease femoral and pedal pulses. Patients may also have dysphagia and hoarseness. So all of these are little things that patients can present with, and you want to make sure you know what you want to associate it with. Now, if we look at these pictures here, so above this one here, right, you always want to know what normal looks like. So that's your normal thyroid gland, right, with big, round, nice follicles, very smooth in the center, right? They call it homogeneous colloid. That's your homogeneous colloid, right? There's nothing in there. No little dark spots, nothing in there. That's your normal thyroid right there, right? And you want to make sure your colloid stuff is, like, they shouldn't all be tiny like that. There should be big ones, right? A is the erythroid cell we talked about with Hashimoto, but the more important thing for Hashimoto was lymphoid aggregates with germinal centers. B and C show you your cretinism stuff, right? So the 6 P's. D is your renal thyroiditis. So you can see now you have the fibrosis, right? Inflammatory infiltrate and fibrosis. And you don't see that in normal thyroid. Right? So all these little black dots, if you want to call it that. The last one is a goiter that you can get in iodine deficiency. Right? If you have iodine deficiency, you get a goiter. What a goiter basically is that it's a very, very powerful thyroid gland. It's ready. As soon as this patient gets any iodine in that body, on that tongue, and they swallow some iodine in them, what was I trying to say? Oh, as soon as this person gets any iodine in that thyroid gland, they're going to make so much thyroid hormone that they're going to instantly become hyperthyroid, and that's going to be a really, really bad problem. Right? So there's something called the Wolff-Chaikoff effect, right? Thyroid gland downregulation in response to increased iodide, right? So thyroid off, as in you turn it off. You turn off the thyroid gland because there's too much iodide. In iodine deficiency, when you finally give them iodine, that's a different effect, and we're going to see that right here called the Jod-Basedow phenomenon. I'm skipping over a couple things just to make a point. So this is iodine-induced hyperthyroidism occurs when a patient with iodine deficiency, which means you have a goiter now, and partially autonomous thyroid tissue, or excessively autonomous thyroid tissue like a goiter, is made iodine replete. Can happen after iodine IV contrast or amiodarone use, which we saw in our antiarrhythmics and cardiovascular is made of mostly iodine. Opposite to Wolff-Chaikoff effect. Right, so there's that. Below is another image of the vein, and you can see two large areas with giant cells, top and center of image, and inflammatory destruction of the thyroid follicles. So if I make it big for you guys, you can see you have your two guys right here. Those are basically your granulomas with giant cells, and that's something that we do obviously not see in our normal thyroid gland, right? So if you see something like this and they tell you this is coming from the thyroid, that's the vein. And the question might even ask you, like, well, what would you find out if you looked at the history of this patient who you have now diagnosed to have the vein? Well, the history of the patient will tell you they were sick. They had some kind of flu-like illness, maybe last week, 2 weeks ago, sometime this past month. All right? So you want to make sure you can make those connections because it's not just about knowing the disease and diagnosing it. Amboss taught one more thing, something called euthyroid 6 syndrome. And I put it into the book because I felt like it was something that can occur pretty commonly. So let's take a look. Decreased T3 can be seen in euthyroid 6 syndrome, right? And decreased T3 we almost always associate with hypothyroidism, but it's not that. A condition, euthyroid 6 syndrome, a condition associated with anorexia nervosa and other severe non-thyroidal illnesses. The decrease in T3 levels in the absence of underlying thyroid disease is assumed to be adaptive, since it may reduce catabolism during states of acute illness or chronic starving. Levels of T4 and TSH may be normal or low. Treatment of euthyroid 6 syndrome with thyroid hormone is not recommended, as thyroid function typically normalizes after correcting the underlying cause, which is what you really need to correct, and that might be the anorexia nervosa. So anorexia nervosa is a pretty high yield topic for step 1, and that's why I put it here. So patient with anorexia nervosa might have low T3, right? And low T3 doesn't exactly mean hypothyroid. Remember that TSH is the actual sensitive indicator of whether or not you're hypo or hyperthyroid, right? So always base your diagnosis off of TSH, not the T3. And this one specific thing you want to keep in mind with euthyroid 6 syndrome is for anorexia nervosa patients, or patients with any kind of eating disorder where they're not eating enough, right? You don't want to have too much metabolism if you're not eating enough. So this is basically your body adapting to that. Next page goes on to hyperthyroidism, of which really there's only one, Graves' disease, and that's really all you need to know. Right, so for hypo, you needed to know 3. There was Hashimoto, there was the vein after a flu-like illness, and then there's the renal with the fibrosis. Here we have Graves' disease, which is a really interesting kind of disease, and it's very common. Most common cause of hyperthyroidism, thyroid stimulating immunoglobulin, which is an IgG type 2 hypersensitivity, actually stimulates TSH receptors on the thyroid, leading to hyperthyroidism, and you get a diffuse goiter. Right? Also, you get dermal fibroblasts, which cause the pretibial myxedema, and orbital fibroblasts, which leads to Graves' orbitopathy. So this TSI, right? This is an autoimmune disease, but you're not attacking yourself. You're actually turning things on. So all the things you're turning on are your thyroid gland, your fibroblasts in your dermal area, and your fibroblasts around your eyes. You're actually going there and stimulating them to do more, and you get all the symptoms you see, painting the clinical picture of a Graves' patient. Activation of T cells leads to lymphocytic infiltration of the retroorbital space, which then leads to more cytokines like TNF-alpha and interferon gamma. That activates fibroblasts, right? More fibroblast secretion of hydrophilic GAGs, leading to an increased osmotic muscle swelling, muscle inflammation, and adipocyte count, all presenting with exophthalmos. Right? But there's no elevation in CK. CK is normal here. Often presents during stress, like pregnancy, associated with HLA-DR3 and B8. So this is a very unique kind of autoimmune disease where you're not really attacking yourself, you're stimulating yourself. autoimmune like Hashimoto's, but these antibodies are specific to the TSH receptor, which they do not destroy, but rather they upregulate it to secrete more T3, T4, and grow. In addition, they also target pockets of connective tissue in the extraocular muscles or the skin overlying the shins. It induces mucinous deposition seen in hypothyroidism, but with a different mechanism here. This pretibial myxedema is non-pitting. The eyes push out, leading to exophthalmos. Targets women more than men. It is definitely more common in women. Treat immune-mediated issues with glucocorticoids. Right, so you have to give glucocorticoids to pretty much stop your immunoglobulin from doing everything it's doing. The only issue is that your glucocorticoids alone don't exactly fix the hyperthyroidism. Right, if you've already got too much T3 and T4 in you, that isn't going to be fixed by the glucocorticoids. So it's going to take some time for that to go away. Histologically, it's very predictable what you're going to see. You're going to see crowded follicular epithelial cells, a lot of colloid, tall cells, because everything is overactive, right? So if we look at image B right here, compared to, remember, the normal thyroid, this does not look like your normal thyroid at all, right? So you're seeing a lot of little black dots. You still have your pink area, but it's not nice and round anymore. So that's what they're talking about when they say scalloped, right? Scalloped colloid. I think this is also an image of that, right? Above we see a histological image shown at high power. The tall columnar thyroid epithelium with Graves' disease lines the hyperplastic infoldings into the colloid. Note the clear vacuoles in the colloid next to the epithelium, where the increased activity of the epithelium to produce increased thyroid hormone has led to scalloping out of the colloid into the follicle. And that's what we're seeing here, all the white space. So this is your thyroid gland, but it's being kind of overworked heavily. A toxic multinodular goiter is basically going to have focal patches of hyperfunctioning follicular cells distended with colloid working independently of TSH. So now your TSH in this case might actually just be normal, but it's the thyroid hormone itself, the thyroid gland itself, that's making too much thyroid hormone. So increased releases of T3 and T4. Hot nodules are rarely malignant, and that's something you definitely want to remember. A hot nodule versus a cold nodule. A hot nodule is hot because it's functioning and it's doing a lot of work and it's making a lot of T3 and T4. A cold nodule has lost its normal function, so that can be malignant, right? It doesn't work anymore. Thyroid storm is an uncommon but serious complication that occurs when hyperthyroidism is incompletely treated or untreated, and then significantly worsens in the setting of acute stress such as infection, trauma, or surgery. Presents with agitation, delirium, fever, diarrhea, coma, and tachyarrhythmia, which is usually the cause of death. So imagine that, a patient presenting with delirium in a question stem, right? How confusing would that be? Patient presents with delirium, they have fever, right, but they don't have any infection, they have fever, they had diarrhea last night, they eventually slip into a coma, and then despite any treatment, they eventually die. And you're just left thinking, what the heck was wrong with them, right? So that's what was wrong with them. And the question can really throw you off. They can even give you elevated liver enzymes, and then you start thinking of hepatitis and stuff. They can tell you the diarrhea and the delirium, and you're thinking maybe it's a medication side effect or something. It's really not. But you can see that this clinical picture that I'm highlighting right here, this clinical picture does not immediately yell at you that this is a thyroid problem, right? You can't even tell what the problem is. And that's because your thyroid hormone works with so many different systems. It affects so much of your body that it actually causes this kind of clinical picture in a thyroid storm. So you have to treat this by treating pretty much all of these issues. So one, you give a beta blocker, because remember, your thyroid hormone actually upregulates beta activity, so you want to block that. So you can give something like propranolol. Propylthiouracil to target the actual thyroid gland itself. Really all that's there for. Alright, so what is it? Reconnection. Okay, anyway. So the potassium iodide is something that a lot of people tend to miss out when they get to a thyroid storm. It's also something that a lot of people forget about when they see it in a question. But basically, if you have a high iodide load, that decreases T4 synthesis. So that's something you definitely want to do for these patients. All right. Graves can present at any time, but shows a tendency to pop up in stress. A patient's thyroid levels may be inadequately managed, and then they might get sick, and that can lead to a thyroid storm with high fever and the lethal consequence is that T3, T4 increases the patient's beta-adrenergic stimulation, leading to tachyarrhythmias. Alright, so the beta blocker is specifically very important here for the tachyarrhythmia stuff, which can actually kill a patient. And we already talked about the jaw-based phenomena. So here in image A, they're kind of just showing you the exophthalmos, so you can see how the eye is really sticking out. Right, and then we already talked about the scalloped stuff here. Causes of a goiter. So now, smooth versus nodular is very much a common sense thing. It's going to be smooth if whatever is affecting your thyroid is affecting the whole thyroid, right? Which is why it's smooth. It's diffuse. It's affecting the whole thyroid gland, not just a segment of it. So that's Graves' disease, where you're obviously affecting the whole thyroid gland. Hashimoto, again, you're affecting the whole thyroid gland. Iodine deficiency, also affecting the whole thyroid gland. And any pituitary adenoma where you're making a lot of TSH, which is also going to affect the whole thyroid gland. So it's all going to be smooth and diffuse. You get nodular goiters and cancerous things, right? Toxic multinodular goiter, adenoma, cancer, or a cyst, where one or a few specific areas of the thyroid gland got affected, and you got a goiter or nodule on your actual thyroid. Radiation-induced damage to the thyroid gland is something relatively new in first aid. They've made its own little thing, but it's not something new to you, or it definitely shouldn't be. And it's not something new to medicine either. But basically, anytime you ever walk into a room where there's a lot of radiation happening, maybe because of X-rays or something, you put on a whole outfit to prevent that radiation from affecting you, right? So there's like this big gown you pull onto yourself. It covers the front, covers your chest. There's also a tiny section, a tiny thing related to the gown that you're supposed to wrap around your neck, right? You wrap it around your neck. Let me see, what is this? Why is this so... I made it HD again. I don't know why it lost its HD aspect. Anyway, yeah, there's a tiny thing that you also wrap around your neck, and it's also kind of just there to prevent the radiation from it hitting your thyroid gland. So you have to remember that anytime you're walking into a room where there is radiation occurring, you got to be fully gowned up, including your head and neck. Ionizing radiation, increased risk of hypothyroidism, thyroid nodule formation, and thyroid cancer, usually papillary, later in life, especially among people exposed to radiation as a child. In the event of a nuclear accident, prevent by administering potassium iodide, because again, Lugo solution decreases T4 synthesis. This will saturate the thyroid gland with stable non-radioactive iodine. Right? So the real issue is that the radioactive iodine is the thing that becomes a problem, and then you end up having thyroid cancer. So you want to prevent a lot of radioactive iodine from reaching your thyroid gland and saturating it. So give them good iodide, and that'll hopefully fill up all the holes, and you can't have any radioactive iodine actually stuck in your thyroid gland. So now on the next page, they start talking about all the thyroid cancers. I'm going to take a little break right now, and then I'll be back, and we'll go into all our thyroid cancers and wrap that up. And then we'll do a lot of practice questions, and I want to show you a couple pictures of things that you can get tested on in terms of anatomy before we finally jump into parathyroid disease.